This week on the Back Table Podcast,
there are at least things that we're saying this is a problem. We need to address it at a systemic level. It can't be a case-by-case basis. It's every single child that needs this access. As simple and straightforward from getting kids in with ear infections who need ear tubes, all the way to really providing the resources for a family with a really medically complex kid to give them the care they need at home to keep them out of the hospital, keep them out of the healthcare setting, and keep them as healthy as we can.
Hello, everybody, and welcome to the Back Table ENT Podcast. My name is Gopi Shah. I'm a pediatric ENT, and I'm here today with my co-host and brilliant partner in this, Dr. Ashley Agan. How are you, Ash?
Hey, girl. Hey. I'm good. Excited to be here with you.
Excited to be here with you.
I love it when we get to co-host. We have a very special guest.
We do. I guess that kind of goes back with both of us a couple years.
Yeah. So Dr. Jill D'Souza is joining us today. She's a pediatric otolaryngologist and assistant professor at Louisiana State University in New Orleans. She practices at Children's Hospital of New Orleans. She is very special and dear to us because, as you mentioned, she overlapped in training with both of us. So we were medical students, bright-eyed, budding otolaryngologists back at UTMB in Galveston.
And we were residents. Yeah, we did some residency together at Jefferson. So it's fun how small the world is. And Jill's a pediatric ENT, just like me. So it's awesome.
Perhaps you inspired her.
Oh, please. Welcome to the show, Jill. How are you?
I'm good. Thank you so much for having me. It really is such a special opportunity to sit here and look at us all grown up and talking about big things now.
We made it.
I very vividly remember back in those days where we were like, will we ever be big grown attendings? And here we are today.
Yep. Time flies. So before we jump into the show, I mean, you're here today. We're going to discuss challenges to providing equitable care to pediatric ENT patients in the Gulf South, where you're practicing. But before we start the show, talk to us a little bit about your background and training and journey and what your practice is like these days.
Sure. Well, you are both witness to my training. As you know, I was in medical school with Ashley at UTMB in Galveston and had the joy of joining Jefferson and Philly and Gopi for 5 years. After that, went to the Northwestern Pediatric program at Lurie Children's Hospital, where I've completed a year of postgraduate fellowship training in pediatric otolaryngology. Started my career at Texas Children's in Houston, and then got invited to develop the head and neck program, thyroid surgery program at Children's Hospital here in New Orleans, which is where I've been for the past almost 4 years now. And it has been really a privilege to bring that kind of expert care to this part of the country, but also really eye-opening in seeing some of the challenges that I didn't even realize were challenges. So it's been a learning experience for me, one that I'm still learning, and I hope I can shed some light on that with you guys today.
Yeah, and most of your practice now is head and neck cancer in kids or neck masses, and particularly thyroid?
Particularly thyroid, but any kind of head and neck cancer. Of course, with that comes needing adjuvant therapies, radiation therapy, chemotherapy, that we have wonderful partnerships with our pediatric oncologists as well as our pediatric radiation therapists, and really providing good multidisciplinary care for that. But of course, you're not a pediatric otolaryngologist if you don't have your lovely tubes and tonsils day, which I certainly still do. So it's not all cancer.
And Jill, how many of there are you in the PD ENT division at Children's in New Orleans?
We are right now a little bit scarce. We're only 4 of us right now, but we are welcoming 3 new partners later this fall. So
wow,
very excited to have that expansion.
That'll be awesome. Congratulations.
Yeah, it's almost doubling. That's great.
We definitely need it. The community needs it, and we do too.
Yeah. So tell us about, we refer to this region called the Gulf South. Tell us just where that exactly expands.
Sure. So the Gulf South really refers to Texas, Louisiana, Alabama, Mississippi, and Florida. When we refer to the Gulf South catchment area, we refer to the areas of those states that come to us most often. Now, obviously, we are certainly not the only expert level pediatric hospital in this region. You've got Texas Children's in Houston. You've got St. Jude and Le Bonheur in Tennessee, which is not exactly Gulf South, but close enough that a lot of patients do go there. A lot of wonderful Nemours institutions in Florida, and of course, Children's in Birmingham, Alabama. But there's a lot of square mileage in between all of these places. It's tens of hours for people to get to any of these hospitals when they live in really rural parts of the Gulf South. So for us, we catch a lot of folks from the eastern part of Texas, the Florida Panhandle, the southern parts of Alabama, and almost all of Mississippi. We catch a lot of those kiddos. So while we are really focused on our mission to the children of Louisiana, we certainly expand to the children in the surrounding states as well that we are the closest or most expert level care for.
And can you talk to us about historical healthcare inequities specific to the region?
So as we all know, the South has traditionally been one of the most heavy strugglers with the use of healthcare insurance, and that all relates to poverty levels in the state. Louisiana is one of the most poor states in the country, so is Mississippi. Wonderful communities and really welcoming people, but have challenges that you just don't have in some of the wealthier states. One is always access to care, simply transportation. Do you have a car that's reliable enough to get you from where you live to the hospital that you need to get care at? Do you have the local providers to help you know when you need to go to a higher level of care? Are you getting the referrals that you need? Or do you have the local community resources to get the care that you do need locally without having to undergo the burden of transportation, finding housing, being away from the rest of your family, taking time off of your job? All of these things that just may not come into your thought process when you live somewhere with less distance between your healthcare providers and your home.
You had mentioned there's a lot of out-of-state folks that you guys take care of. Is that difficult when it comes to health insurance, or, how do y'all work those patients in? Or is there like a system set up to make that access a bit easier for the out-of-state folks?
We do our best to make it as easy as possible, and we do have a department in our hospital that helps with access. We have almost like a concierge service in that they look and see what services does this child coming from out of state need, what are the insurance requirements to be able to go somewhere. There are things that are easier than others, of course. Just like anything else, when you have a private pay insurer that you can appeal to and get approval to do something such as travel or go out of state for a specific care that is not available to you locally, things get a little bit harder when you're out of state and on a government-funded program such as Medicaid. Here in Louisiana, we've been fortunate to have some really passionate people involved in the care of children here in Louisiana, specifically one of my previous partners, who's now the chief of otolaryngology at Nemours in Orlando, Dr. Adele Evans. She pushed through some great legislation that has requested the state to monitor and fund a program for children that are technology dependent at home. So, for example, children who have ventilators, tracheostomies, things like that, where you live in the middle of nowhere with 6 hours to your closest emergency room. If you have a home monitoring system that can be remotely accessed, then you have a little bit more of a safety net. And that is still in process. We're hopefully supposed to hear back about that later sometime over the summer, and hopefully that will go into use. So we're really excited to see how that works out.
Yeah, I think there's a lot of things kind of in the technology realm that have the opportunity to really help underserved areas. So like something as simple as like being able to have that remote monitoring for a patient who's 6 hours away from their nearest specialist that would know what to do. I mean, these days, potentially a small thing to implement, but can be a huge impact for the patient and patient care.
I think just like everything else, technology can make things so much simpler and sometimes a little bit harder at the same time. It's always that balance. But for our kiddos that have no other ways of being seen, like when you have access to telemedicine, as we all saw during the heights of the pandemic, we all expanded our telemedicine access. I mean, as the three of us here can attest to, it's pretty hard to practice otolaryngology via telemedicine. You can't really look in the places you want to look. But we adapted and we learned how to use that technology to our advantage. And that's how I feel about home monitoring programs. They're not perfect. They can't be used in isolation, but they really provide an option for the gap in care that exists right now and provides a safety net for kids who are going home to places that don't have easy options for a quick healthcare check.
Thinking about your kids that you're taking care of, how many of them have even just a local ENT that is comfortable doing a wound check or changing their trach or things like that? Are most people depending on coming to see you for all of their care?
So we have a really robust tracheostomy program. So whenever you are a candidate for a tracheostomy at our institution, the parents or caregivers of the child have to go through a pretty intensive course of learning how to care for the trach, change the trach, providing CPR to their child, emergency measures, using a trach and a downsized trach, or even having an emergency go bag. And they have all that available to them. And we make sure that they don't leave the hospital without those things, so that if they are ever in a situation where they are in a healthcare setting, I oftentimes tell folks at the other institutions that the parents are the experts here. Like, they are usually better trained to take care of the trach emergency with support than even some of the local providers if they're not experienced. But to that purpose, I think education of the local providers is essential. And that's another thing that we focus on, is trying to provide the literature to the local communities. When we know where the families are going, we try to reach out to their pediatricians and kind of say, hey, this is what's going on. These are the things that we expect. These are the things that can happen. And these are the things we want you to be watching out for. And here's how to manage them. And we've really had good success with that. We have a tracheostomy clinic where patients with tracheostomies come in and see ourselves, as well as our pulmonology, GI colleagues, speech therapists, respiratory therapists, and our social workers, all in the same clinic. So we try to streamline that care as much as possible, and more importantly, try to prevent issues. I think if we're able to prevent things, we do much better than trying to fix them after they've already happened. And that's where we focus so much of our attention these days.
Talk to me a little bit about prevent issues in these trach kids. What are some of the things that, you're checking for, assessing for, screening for, so that families aren't out, at home 6 hours away, to prevent these fires, or trouble that can happen?
So just like everything else, it starts with education and comfort. For a lot of us, we all remember this as medical students looking at a tracheostomy and being like, oh, that is scary. That is a hole somewhere that a hole does belong. And we don't really understand it. And as you get more comfortable with it, now you don't think about it twice. It's just another way of providing access and care to a different part of the body. So we first teach, just don't be afraid of it. And then we teach how to manage it and troubleshoot. Like this morning, we were troubleshooting some of my technical issues with the computer. The parents how to troubleshoot the technical issues with the tracheostomy. It is learning, okay, this isn't working. Here are the 3 next steps I've been taught. I've been taught to suction this tracheostomy. I've been taught to manually bag. I have been taught that if I can't get this suction to pass, I change this trach out. And I know how to do that because I was taught how to do that too. And that's why we feel so strongly about our tracheostomy program. It can be a lot because it's a lot of reliance on the families and a lot of pressure to learn all these things. And another huge issue that we're facing here in Louisiana and nationwide is the massive nursing shortage that we're facing. I think by 2030, it's estimated that only about 40 to 50% of nursing positions will be filled at the current levels. And we have the real support of nursing schools around the state that are really working hard to provide Louisiana grads who are interested in staying in the state with options to get their BSN in nursing more efficiently, and to provide them with the training to be able to provide that local rural care. But just like everywhere else, the lack of nursing is really what gets our families, because a lot of people
in their insurance actually qualify for home health, or they qualify for nursing visits, and they have the financial wherewithal to be able to have this, but no nurse is available. And it is a really eye-opening thing that I'm not sure a lot of providers who recommend trach or families who make the decision to proceed with a tracheostomy realize that a lot of the times they don't have the help at home that they deserve and are entitled to, just because of this manpower shortage.
And is that, the shortage of nursing, and specifically, I would imagine that impacts people who live in more rural areas even more so? Because, if there's an overall shortage, I would imagine if you also happen to live in a place that is not as populated, that you would really have a hard time, getting help.
Most definitely. And especially if we're now moving out of state. Here in Louisiana, we have some legislations that have been passed to help children who are tracheostomy dependent. We have Louisiana waiver program that if a child has been in the hospital for 60 or more consecutive days, that we can provide more assistance to the home in terms of DME supplies and things like that. And I believe it's up to about $20,000 a year that we can provide, which gives you a nice help for the supplies that you may not have at home. But if, for example, you're coming from Mississippi, that waiver doesn't exist, and we don't have that option, even though we are providing the same care. The going home part is a little bit more challenging. So it really is a big part of our job to kind of find these gaps and see what can we do to remedy them or alleviate them. And sometimes the answers aren't easy, but we're always working at them.
Yeah, realizing it's not, nursing level care, or do you see a role for community health providers, or have there been any programs like that where you've seen, it's manpower, it's education, it's support? Have y'all had any experience with that within the hospital or in ENT?
We definitely provide education days where we welcome folks in to come and learn about it, but we don't go out to the communities to do so, where I think that's, again, another barrier because, maybe a local provider doesn't have the ability to take, a day or two off and come to New Orleans for this program and leave their own home uncovered. It can be really challenging, but having a really formalized education program and having the resources at the Children's Hospital to be able to provide as much help as we can is the best we can do. And of course, every single tracheostomy patient who leaves our hospital has an entire sheet with our contact information on it, and we're on call 24/7 so that any local or community provider can always reach out for help. And they often do. And oftentimes they end up in emergency rooms and get transferred back to us. And whatever we can do to make kids safe, that's what we want to do.
We talked about the tracheostomy child, which has so many different equipment needs, nursing needs, education needs, supply needs, and it's over such a long period of time. I mean, potentially lifetime. What do you find in terms of the challenges in this context when it comes to post-op TNA care? Do you find that you tend to admit maybe, do you admit because they're a little bit farther away, or you know what, if it's going to bleed though, it's not going to be for post-op a week later. So it doesn't, how do you think about the TNA care when the access is difficult too?
That's a great question. I know that when we talk about inequities, it's really easy to focus down on kids that are really medically complex like tracheostomy. But if you look for what's most common, it's going to be the kids with sleep apnea getting their adenotonsillectomies. So I follow the AO guidelines for the most part: admission under age 3, admission for moderate or severe sleep apnea, and we also admit for distance of over an hour. Obviously, that does not help with the late bleeds or the secondary post-tonsillectomy hemorrhages. But if there were to be a primary hemorrhage, then they would be in-house. And I feel more comfortable with that. And I know my partners do as well. In terms of how we help with that kind of access, though, we've been able to partner with a rideshare car program that within 50 miles of the hospital, we can actually arrange for transportation, which has been a really great benefit for kids coming for their preoperative visits, for the day of surgery visits, having transportation after surgery, but even coming back for emergency care. It's not perfect because it only goes up to 50 miles. I believe that's the limit, but it's an option that wasn't there before, and that has helped us decrease our no-show rates. It has helped us make sure that kids who have sleep apnea are getting the treatment they need instead of someone's saying, oh, you know what, they're just snoring. It's not that big a deal. We can wait for a while. But we're getting the access and we're getting the surgeries and we're getting these kids back to sleeping well, waking up rested, being able to participate in their daily life activities with attention and really helping improve the quality of life for the family.
That's awesome. And things like that require looking at something like no-show rates and asking the why. Because some people would look at a no-show rate and be like, oh, we just need to implement an automatic text reminder. Maybe people are just forgetting. But you have to kind of dig down and then you realize, oh, people aren't making it because they don't have a ride. And so then you develop a program and now people have a ride and now kids are getting the care they need. So it's like little programs like that, small little interventions that can chip away at this bigger problem and provide these solutions. Even if it's just 50 miles at this time, like at least you're helping the kids within that radius be able to make it to their appointments, which is awesome.
I'd love to say we came up with the rideshare idea in a strike of brilliance immediately, but no, this has absolutely been trial and error and realizing that the text messages alone weren't working, the phone calls the day before weren't working, and we were still seeing kids that we knew needed to come in and for whatever reason not making it. It was the car breaking down. It was the ride that was supposed to be there not showing up. And once we were able to partner with this rideshare program, it's really made a difference, and we've seen that. And we've been fortunate in that support from our administration trying to look into these areas of inequity that we can address.
Are there other gaps that come to mind when you think about your patients? I mean, transportation is a big one. Anything else that, is kind of on your radar that you're thinking about these days?
Well, transportation is always a big one. Median household income is another. We've mentioned it earlier in this chat that Louisiana has some of the highest poverty rates in the state. So things as straightforward as go pick up some ibuprofen or go pick up some acetaminophen, no big deal, right? It's over the counter. Some families can't afford that over the counter. We have been able to start a pharmacy here at our institution and cover that gap a little bit as well, but still run into some financial issues that we're continuing to work through. It's a work in progress. But I was actually speaking to my thyroid surgery nurse coordinator just yesterday, and we were chatting about the difficulties of levothyroxine. So in adults, right, you give the little tablet, no big deal, fairly cheap, not too hard to get, covered by Medicaid, Medicare, all insurers, right? When you're thinking about kids, and specifically small kids under 12 kilos or so, although the capsules are very easy to crush up, and you can do that for older kids, when you're talking about a child who is really, really little and needs a liquid formulation, those are incredibly hard to get, not only from is it available, but from how much does it cost? The two most common formulations, one is a liquid and the other is a single dose ampule. And in terms of maintaining thyroid level stability, you want to be taking these every day at the same time, exact same dose. And for some reason, what we've seen is with the liquid formulation, the most common liquid formulation and the one that is used, that is on Medicaid formulary, has a harder time getting you to a thyroid level homeostasis, whereas the liquid ampule, that you're opening the ampule and putting that exact amount in the mouth every single day, gets there better. But that one's not on the Medicaid formulary, and that one is very expensive. To that same level, things as common as eardrops. How many times you say you prescribe an eardrop in your day-to-day? I, to this day, couldn't tell you which insurance covers what. Floxin is most often covered. Ciprodex, the brand name for Floxin with dexamethasone, is often not covered. And if you don't have insurance coverage for that drop, it's anywhere between $200 and $350. And I don't know about you, but I wouldn't be super excited about going to the pharmacy and dropping $250 for a bottle that is the size of your thumb.
Well, and even with insurance, sometimes those medications, specifically certain eardrops, can be very, very difficult to purchase for families.
So it's really in every aspect of what I do. Every single prescription that we send, I'm like, oh, will this family be able to afford it? And that's an answer that I don't always have.
So it's so interesting when I think of the Gulf South, and I'm from Shreveport, which is the Gulf South, but it's in Louisiana. It's northern part of Louisiana. My husband and I, we were in New Orleans for medical school. We were there in the middle of our medical school was when Katrina hit. So I think about, Hurricane Katrina, I think about COVID, and then that's recent stuff, right? And you think about all those different states that you named in that area, right? There's so many different states, as well as then you have the historical poverty, racial inequities. We're talking about the Deep South. There's so much when you think about all the different layers of how you can describe the Gulf South and all the different factors that can play a role in, where we are today and what's easy to get, what's not easy to get, whether it's access to care, workforce, medications. Tell me, who are some of the players involved when it comes to helping make some of these improvements, whether it's from the rideshare program to, even having some of, Motrin and Tylenol in the hospital, which is huge, because at least, you can give something in hand to your patients before they go. With all those factors, how do you think about it? Like in terms of who am I going to use or what systems can I use to help me make some of the changes?
So I think it all starts with us, right? It is identifying a gap and then really fighting to see what can I get here? What can we do to help? By no means what we're going to talk about will it be a comprehensive review of all the barriers down here in the Gulf South. We haven't even touched on racial inequity, which is a huge component in the South. It's the mistrust in the medical system for a variety of reasons, some of them truly with good reason, and things that happened with Katrina, for example. If you've ever seen the documentary about the Charity Hospital here in New Orleans, it's really eye-opening. It really highlights what happens in a community where you've had a safety net catchment hospital for decades, and it got literally washed away. And you now have large corporations coming in to rebuild a healthcare system in the model of every other healthcare system in the country, which just doesn't always work in the Gulf South. To your question about partners, we work very closely with local government agencies. Our administration has given us the support that we needed to be able to set forth that legislation that my former partner, Dr. Evans, did with the state of Louisiana. We've had some Congress people very interested in helping promote our hospital and promote our mission. And the mission of the Children's Hospital of New Orleans is truly to provide all care equitably to every child in Louisiana. New Orleans in particular is just a really unique location given its rich history and also its history of really difficult hospital changes. Charity was a hospital that had been here for decades, really had the trust of the community, and Hurricane Katrina really impacted that care, not only from an access standpoint for all the folks that it had been there for all that time, but also now they were having to find new healthcare homes that might not be as welcoming because of new insurance requirements. Charity took everyone and didn't ask a lot of questions. And as we all know, all healthcare institutions ask a lot of questions these days.
I think even the county hospitals, I trained at Parkland in Dallas. And, from the time when I was an intern, when I started residency, it was take care of everyone, not asking a lot of questions about your funding or this or that. But even in those 5 years, by the time I graduated, there were more people with clipboards coming around trying to understand if the patient was coming from somewhere where they had funding, where they needed to go to, if they're out of county, they need to go back to where, they are to receive their cancer care or whatever it is. And so even in these places that were historically kind of like the safety nets, those financial pressures are coming to those places now, and it's different than it used to be.
Yeah, and I don't feel that we're all very advanced in our careers and have been doing this for decades upon decades. I've been in practice for I think 7 years now, which is not nothing, but it's enough to be able to really see the change that has happened, for better or worse. I mean, it's not an efficient way to run a business, but none of us got into this for the business. We got into this to help people, to take care of people, and sometimes that feels hard to do sometimes.
Yeah, and maybe you can speak to it a little bit more, but for children, Medicaid is the government insurance, but Medicaid is run by states, correct? So if you have kids coming from different states, they have technically kind of have different versions of Medicaid.
They may have different versions of Medicaid that cover different things. Louisiana Medicaid is a little bit different than Mississippi Medicaid, specifically because of things like that waiver program that we mentioned earlier that is available to Louisiana Medicaid recipients, but not to Mississippi Medicaid recipients.
And Mississippi's like 2 hours away, right?
An hour and a half.
An hour and a half. Yeah, it's right there.
Yeah, it's. I mean, there are clinics in Louisiana that we travel further to than our Mississippi families. Children's has clinics as far out as Lafayette, and that's, I think, 4 hours away. 3.5. Well, it depends on who's driving and how you drive. About 3.5 to 4 hours.
I would recommend not driving too fast on 10. I feel like I got speeding tickets constantly from my drive of Shreveport to New Orleans, and there was definitely that chunk after 49 South on 10. So drive slow, y'all.
So in the adult population, like with Medicare, it's more uniform. And so with Medicaid being different and specific for states, I just feel like that can make it really tricky. I mean, I imagine in a tertiary healthcare hospital like you're in, that you have social workers and case managers, a team to kind of help navigate.
We have an entire group of people, truly the unsung heroes of insurance, are social workers and case managers. Like, they do the work that none of us even remotely understand how they do it, but I'm grateful for them every single day. They really help find every single amount of funding that each family can have. We want everyone to have every bit of support that we can have. And here at Children's, we also, most Children's hospitals have a little fund for folks that we really can't find another option for, that have a little bit too much money to qualify for Medicaid. And by the way, the upper limit of your income to qualify for Medicaid is not a lot of money. And I need to look up the actual number, but it's something like $22,000 a year or something like that.
Meaning that if you make more than that, then you don't qualify?
You don't qualify. For children, there's several different numbers. I'm just pulling it up right now because it's one of those things that just does not stick in my mind. But it's the monthly income for a family with one child is $2,700. So if you make more than that, you may not qualify.
And so for those families, they're basically kind of falling through the cracks then. They make too much to qualify for Medicaid, but they don't make enough to be able to purchase marketplace insurance.
It reminds me of the kids that have some hearing loss, but they don't qualify enough to get the hearing aids. And those are the kids that are going to do the worst in school. They're going to be the ones that fall through the cracks. It's the same.
And it's one of those things that families then end up making decisions, well, if I can get health insurance by not making any money, then I guess I just won't make money, and then we leave the workforce. And then you have the self-perpetuating cycle of never being able to get out of poverty. It's a really complex issue that I don't feel like I can do justice to, because I'm sure there's so many nuances that, as much work as I do in this space, I don't know that it's enough. But it's one that I feel, it's like that Dr. Seuss book, The Lorax, right? It's like, unless someone like you cares a lot, it's not going to get better. We all have to care. It's looking at what you can do at your institution, what protocols can you put in? What safety nets can we do? So we have a financial assistance program at Children's that we're able to provide aid to some families that don't qualify for other programs. We have our own pharmacy benefits in the hospital that we're able to sometimes provide them for a cheaper cost. I myself went to the Children's Hospital because we have a travel clinic there for adults who are traveling to tropical areas. And I'm going to Africa later this summer. So I went and I got prescribed Malarone, right? And azithromycin to just take with me. And I got a text from my hospital as soon as I left saying, hey, if your insurance doesn't cover this, here is a coupon from the hospital to ensure that you are paying the lowest price available to you on this medication. And that was news to me. I didn't even know we had that. And it was a really nice way to see advocacy in action. So it's just making these small changes helps, in a snowball effect, make bigger changes. Because if we see how it works, because investing up front will help you in the long run. Investing in this rideshare program, intervening in these kids who have sleep apnea, getting them to their surgery, getting to their post-op care, means that they are going to do better in school. They are going to be able to participate in sports. They are going to be able to be more attentive during the day. As we've all seen, kids with sleep apnea can sometimes act out in ways that adults don't. It's more behavioral issues. And so you've got these kids getting labels of ADHD or oppositional defiant disorder and things like that, where truly maybe they just aren't sleeping well and they're very tired. And that's how it's showing up. And especially somewhere like Louisiana, where you have the racial background, where kids from African-American backgrounds in particular tend to get labeled with behavioral diagnoses that just aren't accurate. So we want to make sure that we're really careful with these labels and really careful with making sure that kids are getting all the help they can get. There's so much, even food access. What's the cheapest food that you can think of that is available to us? It's going to be fast food. It's your little gas station dollar boudin ball or your McDonald's or whatever is cheap. And if you're talking about getting organic, healthy produce, vegetables, fruit, you're looking at a lot of money for these people. And you're making choices for your family financially completely reasonably, right? Like you need to be able to pay your rent. You need to be able to keep your lights on. And so maybe you're not making the healthiest food choices. So then you end up with kids who might be a little bit further on the obesity spectrum, who again are going to have more issues with sleep apnea. And it just comes into this whole cycle again and again. So it's going to take a lot of us, and it's going to take intervention on so many different aspects. And sometimes it feels like you are just working so hard to just keep your head above water. But we have seen the changes that we can do by taking it one step at a time. The Rideshare program has been a huge success for us in cutting down no-show rates, in cutting down no-show rates for surgery, which is something I never experienced anywhere else. And having the financial access program has enabled us to diminish financial burden on some families that need access to chronic care or need surgeries that would be otherwise inaccessible to them. And things like the pharmacy benefit program being available. And I'd be remiss if I didn't mention some of the tremendous work that the legislature has done in really helping us move forward with the home monitoring program for our tracheostomy kids. It's not finished yet at all, and I hope very much to see the effects of that over the next year to 2 years. But they're steps in the right direction. They're at least things that we're saying this is a problem. We need to address it at a systemic level. It can't be a case-by-case basis. It's every single child that needs this access. As simple and straightforward from getting kids in with ear infections who need ear tubes, all the way to really providing the resources for a family with a really medically complex kid to give them the care they need at home to keep them out of the hospital, keep them out of the healthcare setting, and keep them as healthy as we can.
I think that's a great place to land it. It's so eloquently spoken, and I just love what you're doing, Jill. I just love it. Your patients are so lucky to have you. You're doing the hard work, and you're an inspiration.
Yeah, you're seeing the patients beyond just the pathology. Like there's so much more, right, to a good outcome and a patient and getting them through what if it's a simple surgery to something more complex. So it's really awesome. Yeah.
It's never not frustrating, but it's always worth it. I've pulled my hair out more than once.
Well, do you have any final pearls that you want to leave us with?
I think just really investing in each patient, remembering why it is that we do what we do, really helps keep us on track. And we've all had those patients, right, that come in and you're like, oh, great, here we go. There's some baggage that makes this a really difficult appointment for whatever reason. And it's remembering that everyone in that room, especially in pediatrics, is there for one reason and one reason only, and that's the child. And once you reframe that, everything gets better. There's always a barrier, and if you can alleviate that barrier, you're on your way to making a difference.
Beautifully said. Well, thank you so much, Jill.
Thank you, guys.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BacktableENT on Instagram, LinkedIn, or Twitter. Backtable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.